Cardiovascular disease strikes in every nation around the world. From sudden cardiac arrest to the disabling effects of acute coronary syndromes and acute ischemic stroke, cardiovascular disease remains a leading cause of disability and death in many parts of the world. Understanding and activating the systems of care developed by the American Heart Association can help improve survival rates and may even prevent cardiac arrest. You play a pivotal role in providing high-quality cardiovascular care. What you do matters. What you learn can save lives. Welcome to the American Heart Association's Advanced Cardiovascular Life Support Science Overview video. In this video, you'll be presented with the most recent recommendations on cardiovascular care based on the latest scientific studies. In the next few minutes, we'll outline the changes in the 2010 American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. These guidelines were produced after an exhaustive review of thousands of peer-reviewed publications. We will also review several core recommendations from the 2005 guidelines that continue to be emphasized. We'll approach these changes systematically by first reviewing changes to basic life support, or the BLS guidelines, followed by the newest recommendations for advanced cardiovascular life support, or the ACLS guidelines. Let's begin. The steps in the BLS survey for healthcare providers have changed. Instead of the familiar steps of A, B, C, D, where clearing the airway and breathing come before chest compressions now take priority for the unresponsive patient with cardiac arrest. The guidelines now recommend delivering chest compressions before clearing the airway and giving ventilations. The American Heart Association removed look, listen, and feel for breathing and give 2 rescue breaths from the initial assessment entirely. So the BLS survey now includes these 4 steps. Step 1. Check for responsiveness. Tap and shout, "Are you all right?" Then scan the chest for movement. Here you're looking for absent or abnormal breathing. This can be no breathing or only gasping. If the patient is unresponsive, move to Step 2. Activate the emergency response system and get an AED. Step 3. Circulation. Check the carotid pulse. If you cannot feel a pulse within 10 seconds, start CPR by giving cycles of 30 chest compressions followed by 2 ventilations. Do not spend more than 10 seconds checking for a pulse. Step 4. Defibrillation. As soon as possible, attach an AED or defibrillator, and if indicated, deliver a shock. However, if you determine that the patient is not breathing normally but has a pulse, bypass chest compressions and support the patient with rescue breathing, delivering 1 breath every 5 to 6 seconds. Why was it necessary to change these familiar steps? When an adult with sudden cardiac arrest has ventricular fibrillation or pulseless ventricular tachycardia, the heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early defibrillation. The ABCD sequence often delayed chest compressions as the healthcare provider tried to open the airway and deliver ventilations. By changing the sequence and giving chest compressions first, more patients may achieve return of spontaneous circulation, or ROSC. However, there are cases where healthcare providers should tailor the sequence of rescue actions to fit the most likely cause of arrest. This is true for cases involving drowning or other instances where hypoxia is the likely cause of the cardiac arrest. The American Heart Association continues to place a strong emphasis on high-quality CPR in the 2010 guidelines. This is indicated by a rate of at least 100 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, minimizing interruptions in compressions, switching providers about every 2 minutes to avoid fatigue, and avoiding excessive ventilations. The recommendations continue in the new guidelines because scientific studies continue to link high-quality CPR to ROSC. High-quality chest compressions maintain blood flow to vital organs, especially the heart. One way to measure the effectiveness of chest compressions is with coronary perfusion pressure. Coronary perfusion pressure during CPR must reach 10 millimeters of mercury to potentially achieve ROSC. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the heart. The higher the coronary perfusion pressure during CPR, the better the survival rate for patients. When healthcare providers interrupt chest compressions, perfusion pressure falls dramatically and remains very low until compressions are resumed. Because coronary perfusion pressure measurements are not readily available during a resuscitation attempt, healthcare providers can monitor CPR quality with waveform capnography and intra-arterial relaxation pressure. We'll discuss the details of waveform capnography in a minute, but an end-tidal CO2 reading of less than 10 millimeters of mercury will not achieve ROSC. For intra-arterial relaxation pressures, a reading of less than 20 millimeters of mercury indicates ineffective compressions. To perform high-quality chest compressions, healthcare providers should push hard and push fast. Push hard means the provider should compress the chest at least 2 inches. This is a change from the previous guidelines, which suggested a compression depth between 1.5 and 2 inches. The chest should completely recoil after each compression. If it does not, coronary perfusion will remain low. Push fast means to deliver at least 100 compressions per minute. Scientific studies show that the rate of chest compressions is directly linked to ROSC and neurologically intact survival. It can be difficult to maintain such a vigorous pace, which is why the American Heart Association recommends that rescuers switch roles after 2 minutes or 5 cycles of 30 compressions and 2 ventilations. Another characteristic of high-quality CPR is minimal interruptions in chest compressions. Studies demonstrate that even healthcare providers interrupt compressions far too often and for too long, in some cases spending 25 to 50% of a code without delivering chest compressions. The American Heart Association cautions providers against spending more than 10 seconds checking for a pulse or assessing the patient. Rescuer fatigue can also impact the quality of compressions. That is why the American Heart Association recommends switching rescuers about every 2 minutes to avoid fatigue. Finally, high-quality CPR must avoid excessive ventilation. For arrest patients, appropriate tidal volumes should be approximately 500 to 600 milliliters, enough to see visible chest rise. This is about half a squeeze of an adult ventilation bag. Excessive ventilation can cause not only gastric inflation and resulting complications, but can also increase intrathoracic pressure, decrease venous return to the heart, and lower cardiac output and chance of survival. In terms of defibrillation, there are no major changes in the guidelines. The emphasis remains on a fluid integration of defibrillation within high-quality CPR. Healthcare providers should start chest compressions and use the AED as soon as possible for the best patient outcomes. The AHA still recommends the one-shock protocol for VF and pulseless VT. Let's review the changes to the BLS survey, which is now made up of these 4 steps. Check the patient for responsiveness. Activate the emergency response system and get an AED. Circulation. Check the carotid pulse. If you cannot detect a pulse within 10 seconds, start chest compressions immediately. Give cycles of 30 chest compressions followed by 2 ventilations. Defibrillation. If indicated, deliver a shock with an AED or defibrillator. Here are the critical concepts for high-quality BLS. Push hard and fast. Allow complete chest recoil after each compression. Minimize interruptions in chest compressions. Switch providers about every 2 minutes to avoid fatigue. Avoid excessive ventilations. BLS is the foundation for ACLS. The better these steps are performed, the better the patient's chance of survival. There are 4 general categories of changes to the Advanced Cardiovascular Life Support Guidelines. Changes to the cardiac arrest algorithm, the addition of a new immediate post-cardiac arrest care algorithm, and updated recommendations for airway management and synchronized cardioversion. Let's start by reviewing changes to the cardiac arrest algorithm. The 2010 guidelines simplify the algorithm and create a circular chart to emphasize the interventions that have the greatest impact on outcome. The priority is the 2-minute continuous period of high-quality CPR and defibrillation. All advanced interventions, including IV access, drug delivery, and advanced airways, should not interrupt chest compressions and shocks. Rather, they should be performed or administered strategically after the brief pause for defibrillation. These actions continue until ROSC, when healthcare providers will initiate post-cardiac arrest care protocols. Within the cardiac arrest algorithm, there are several drug administration recommendations for both cardiac arrest and non-arrest patients. For patients in cardiac arrest, the use of vasopressors and antiarrhythmics continue, consistent with the 2005 guidelines. During cardiac arrest, providers should administer a vasopressor every 3 to 5 minutes. Epinephrine is commonly used, although vasopressin can replace the first or second dose of epinephrine. Regardless of the vasopressor given, one should be delivered every 3 to 5 minutes. ACLS providers should administer amiodarone for refractory VF and VT. However, the American Heart Association no longer recommends atropine for routine use in managing pulseless electrical activity, or PEA, or asystole. The available evidence indicates that atropine is unlikely to have a therapeutic benefit. If the origin of the regular, monomorphic wide complex tachycardia is unknown, ACLS providers may use adenosine in the initial treatment and diagnosis. However, for irregular wide complex tachycardias, adenosine should not be used because it may cause degeneration of the rhythm to VF. For symptomatic bradycardia, atropine is the first-line treatment for all symptomatic bradycardias, regardless of type. The American Heart Association now recommends intravenous infusion of chronotropic agents as an equally effective alternative to external transcutaneous pacing when atropine is ineffective. Although defibrillation recommendations did not change, there are new recommendations for synchronized cardioversion. For unstable atrial fibrillation, the guidelines recommend that the initial biphasic energy dose be between 120 and 200 joules. For unstable SVT or unstable atrial flutter, the guidelines recommend that the initial biphasic energy dose is between 50 to 100 joules. Cardioversion with monophasic waveforms should begin at 200 joules and increase in stepwise fashion if not successful. The guidelines also recommend cardioversion for unstable monomorphic VT with a biphasic or monophasic initial energy dose of 100 joules. If there is no response to the first shock, it is reasonable to increase the dose in a stepwise fashion. The AHA gives a range of biphasic energy doses because of the differences in manufacturers' recommendations. If the initial shock fails, providers should increase the dose in a stepwise fashion. The return of spontaneous circulation, or ROSC, is no longer the end of the cardiac arrest protocol. More and more scientific studies conclude that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. That's why the American Heart Association has developed the immediate post-cardiac arrest care algorithm. This algorithm can guide EMS systems and medical centers in offering a structured and integrated system of care for patients who achieve ROSC. The goals of this new algorithm are to provide guidance for pre-hospital personnel in transporting the out-of-hospital patient to an appropriate facility with post-cardiac arrest care, provide guidance to hospital personnel for transporting the patient to a critical care unit capable of providing post-cardiac arrest care, identify and treat the causes of the arrest and prevent a recurrence, optimize cardiopulmonary function and vital organ perfusion, especially to the brain and heart. Other objectives of immediate post-cardiac arrest care include considering hypothermia to optimize survival and neurologic recovery, identifying and treating acute coronary syndromes, reducing the risk of multi-organ injury, gathering data to assess recovery, and offering rehabilitation services to survivors if needed. Brain injury and cardiovascular instability can indicate whether a patient is able to survive after cardiac arrest. Therapeutic hypothermia is the only intervention that has been shown to improve neurologic recovery. That's why providers should consider hypothermia for any patient who is comatose after ROSC, and particularly for patients with out-of-hospital cardiac arrest with VF as the presenting rhythm. Several studies show good outcomes for patients whose bodies were cooled to 32 to 34 degrees Celsius for 12 to 24 hours. One study followed cardiac arrest patients who were comatose on arrival at the hospital and received hypothermia treatment. In 3 separate studies, 20 to 50% of those patients had good neurologic function 1 year later. Hospital personnel should not delay reperfusion therapy for ST segment elevation myocardial infarction or STEMI patients during post-cardiac arrest care. It is safe to combine percutaneous coronary intervention or PCI and hypothermia after cardiac arrest. Rapid transport to the catheterization lab remains the focus for STEMI patients.
Critical actions for post-cardiac arrest care include optimizing hemodynamics and arterial oxygen saturation, monitoring airway placement and ventilation status with quantitative waveform capnography in intubated patients, acquiring a 12-lead ECG, and inducing therapeutic hypothermia.
The next category of changes relates to managing the patient's airway. The American Heart Association has incorporated several new recommendations into the 2010 guidelines. The first is quantitative waveform capnography. Waveform capnography monitors the amount of carbon dioxide exhaled by the patient. It's the most reliable indicator of endotracheal tube position during cardiac arrest. It also serves as a physiologic monitor that provides information about the effectiveness of chest compressions, ROSC, and adequate coronary perfusion. The guidelines recommend using waveform capnography to verify placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of other advanced airways. However, effective ventilation through one of the other advanced airways should produce a capnography waveform. A normal CO2 waveform looks like this. When we exhale, carbon dioxide leaves the lungs. The measurement of the amount of carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Providers can use waveform capnography to monitor CPR quality and detect ROSC. Ineffective chest compressions will produce a low-end tidal CO2 reading, even if the healthcare providers are effectively ventilating the patient, because blood flow through the lungs will be poor. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Other recommendations that relate to managing a patient's airway during cardiac arrest include cricoid pressure. Do not routinely use cricoid pressure during cardiac arrest. Studies show that this technique is difficult to master and may not be effective for preventing aspiration. It may also delay or prevent placement of an advanced airway. Agonal gasps are not effective breaths and should not be confused with normal breathing. Failing to recognize agonal gasps may delay important life-saving interventions. Across the United States, survival rates for cardiac arrest, acute coronary syndromes, and stroke vary considerably from region to region. It's important that EMS and in-hospital providers work together, not only to deliver patient care, but to strengthen the chain of survival for future cardiovascular patients. That starts with identifying the weak points in your system's chain of survival. Gathering data and measuring patient outcomes can identify areas that need improvement. The 2010 guidelines are very clear on this team approach. To deliver the highest quality patient care, there needs to be an integration of community, EMS, physician, and hospital resources. This applies acutely to the STEMI chain of survival. If community members are trained in recognizing the signs of acute coronary syndromes, EMS can be quickly mobilized for patient treatment. An out-of-hospital 12-lead ECG is essential to provide advance notification of a STEMI case to the receiving ED. This advanced notification reduces the time from the patient's onset of symptoms to reperfusion with PCI or fibrinolytic therapy. The goals to treat the patient with reperfusion are PCI within 90 minutes of arrival at the ED, fibrinolytic therapy within 30 minutes of arrival at the ED. Because of the time-sensitive nature of the treatment, the guidelines encourage the transport of cardiac arrest patients to PCI centers or PCI-capable facilities. In patients with stroke, integration of care is equally important. In these cases, time is brain. The sooner patients with ischemic stroke can receive fibrinolytic therapy, the higher their rate of neurologic survival. Beyond an appropriate time interval, therapeutic options for these patients become much more limited. Much like patients with acute coronary syndromes, the stroke chain of survival starts with bystanders recognizing the symptoms of stroke and activating the emergency response system. EMS providers evaluate the patient and alert the receiving hospital if they suspect a stroke. If possible, EMS providers should transport the patient to a stroke-prepared hospital that offers best practices of comprehensive stroke care. If the diagnosis ultimately reveals an ischemic stroke, the hospital has 3 hours from the onset of symptoms to administer fibrinolytic therapy. The 2010 guidelines recommend that whenever possible, EMS should triage the stroke patient to a hospital where stroke care is offered. Patients experience improved survival rates and better functional outcomes and quality of life when treated at a hospital that specializes in stroke care. The American Heart Association recommends that all eligible patients receive fibrinolytic therapy as soon as possible within the first 3 hours from symptom onset.
For a select group of patients, the fibrinolytic treatment window has been extended from 3 to 4.5 hours. At the time the 2010 guidelines were released, this treatment window was not FDA approved, but it is recommended by the American Heart Association, American Stroke Association Science Advisory. Some patients may benefit from advanced treatments even beyond the IV fibrinolytic time window. Regardless, urgent transportation to a comprehensive stroke center is recommended for acute stroke patients.
So let's recap the changes to the ACLS guidelines. The American Heart Association has simplified the adult cardiac arrest algorithm. The American Heart Association no longer recommends atropine for routine use in the treatment of PEA or asystole. The treatment of cardiac arrest no longer stops at ROSC. New, immediate post-cardiac arrest guidelines optimize cardiopulmonary function and vital organ perfusion, especially to the brain and heart. ACLS providers should consider hypothermia for every patient who remains comatose after ROSC because it is the only intervention that has been shown to improve neurologic recovery. Quantitative waveform capnography can reliably confirm the placement of an endotracheal tube and monitor CPR quality as well as ROSC. Finally, to deliver the highest quality patient care, integrated systems of care should include community members, EMS, physicians, and hospitals. In the 5 decades since chest compressions were first attempted on a cardiac arrest patient, there have been significant improvements in the treatment of acute cardiovascular disease. There is much more work to be done. With the latest research pointing to new, quantifiable ways to improve patient outcomes, advanced providers have more tools than ever before to reduce disability and death caused by cardiovascular diseases and stroke.